Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk. Welcome everyone to Mountain West AETC Echo. Very happy to be here. Very happy to have Dr. Liss back with us. And without further ado, we'll get going. I'm going to revisit pneumocystis prevention and treatment, some topics we've discussed in the past, and then some updated thoughts and data. Parts of this will be review from when I talked about pneumocystis last time, and we will have a couple of polling questions, so please get ready for those. If you saw me talk about this topic last time, this will be review, and if you didn't, there may be a little bit of updated learning here. So I have no conflicts or relationships to disclose. We'll acknowledge funding from HRSA, and then we'll give you an outline of what I will cover today. So on the prevention side, we will talk about criteria for starting and stopping pneumocystis prophylaxis. We'll talk about how we choose the prophylactic medication and some other considerations around prevention. And then we'll turn to treatment, including choosing antibacterial agents for mild to moderate or severe pneumocystis. A reminder, it is okay to abbreviate this as PCP for pneumocystis pneumonia or PJP, referring to the human-specific organism species. And we'll talk a little bit about adjunctive therapy and considerations if the person doesn't seem to be responding to pneumocystis treatment. But first, review, or if you're newer or haven't heard me talk about this before, maybe this will be a bit of learning. But quick question for you, please go ahead and respond by Zoom. What kind of organism is pneumocystis? Bacteria, virus, protozoa, or fungus? Seems like it should be a straightforward question for reasons we've talked about in the past. It is not. But I do think it's important. So please go ahead and vote, and we'll just give it 4 or 5 seconds here, and then I'll ask Adrian to display the poll. Again, it seems like it should be straightforward, but it is not. It has been controversial over the years. It has been debated, but the answer is fungus, and this is now definitively proven that pneumocystis is an atypical unicellular fungus. And again, I think this is important because we don't treat pneumocystis, as we'll talk about, usually with, or ever, with traditional antifungals. We don't treat it with amphotericin, we don't treat it with azoles. We'll talk about why. One more question, slightly more advanced here, but again, important for reasons we will discuss. What is unique about pneumocystis compared to other fungi? So it is a fungus, that is definitively proven, but what makes it unique? Giving you a couple options here. You can read through those. Cell wall contains a polysaccharide called galactomannan. It lacks common fungal cell wall components like ergosterol. It grows as broad hyphae with right apical branching visible in culture, or it's dimorphic, meaning it can exist as a mold or yeast depending on the temperature. Please go ahead and weigh in. Guesses are fully acceptable. Give you 4 or 5 seconds here, then we'll move on. Okay, bit of a spread here, but 57% did get the correct answer. Lacks common fungal cell wall components like ergosterol. So this is what makes it unique compared to other fungi. There are other attributes about it that led to it being thought of for a long time as a protozoa, but again, it is a fungal organism, but it's unique. It uses mostly human cholesterol for its cell wall and not ergosterol, which is why drugs like amphotericin and azoles don't work, and when we think about the mechanism of those drugs. So A here really was referring to Aspergillus, C more the Mycorrhizales, Zygomyces, those sorts of organisms, and then D, the dimorphic fungi, are the Cocci, Blasto, Histo, and a few others, but not pneumocystis. So I was looking for B, which again I think is relevant when we think about the agents we use for prevention and treatment. So let's talk about pneumocystis prevention. One very important point to remember is who has an indication for pneumocystis prophylaxis. So per the opportunistic infection guidelines, the strongest recommendations, the A1 recommendation, is a CD4 count below 200. I think all of you are very familiar with that. The B level recommendations are more a consider recommendation, so certainly should be considered for anyone with a CD4 percentage below 14%. So I would keep that in mind. I do generally find it useful to look at the percentage of CD4 T cells in addition to the absolute number. We've talked about some instances in which these might be discordant. You might see a much lower absolute CD4 as compared to what's expected with a percentage in someone with portal hypertension, splenomegaly, and the opposite phenomenon after splenectomy. So certainly we can see some discordance, but generally helpful to look at both in addition to looking at the viral load. The guidelines also give this consideration to starting prophylaxis for someone with a CD4 count that is approaching 200 in whom you can't monitor the CD4 frequently. They give the example of someone who is not taking ART and for whom you can't recheck the CD4 count every 3 months. Certainly would be logical to offer prophylaxis in that situation. And then I added this one, if I see someone in clinic, for example, for their first visit, and they clearly have oral thrush or hairy leukoplakia or Kaposi sarcoma or some clear AIDS-defining illness that makes it obvious that the CD4 count is likely to come back below 200, I have a low threshold to offer prophylaxis, especially if I'm not sure how soon they'll get labs or how well they will follow up. So that's my opinion and addition there. But let's talk about the prophylactic options. I've given you here the list, and I've given you them in order of how I really consider them, with trimsulfa being the one I generally consider first, and we'll talk a little bit about the dosing. It certainly is the most tried and true, has the most clinical experience, has the most data behind it, has been shown in clinical studies to be more effective at preventing pneumocystis than dapsone or atovaquone, both of which have been shown to be more effective than inhaled pentamidine, which was shown to be more effective than placebo, but has some limitations around it, which we'll talk about. Now, the dosing of trimsulfa for pneumocystis prophylaxis, I think is an area where there's a bit of variability in clinical practice, and I don't know if there's one right way. You can see here the level of evidence and the options. My strategy has generally been to recommend a double-strength tab daily. I think it is certainly effective for preventing pneumocystis if the person adheres to it, and clear that that also prevents toxoplasmosis for an individual at risk for that reactivation disease. A reminder, the people who are at risk for toxo really are the individuals with CD4 below 100 who have a positive IgG because it is a reactivation disease. A single-strength trimsulfa tab has been shown to be as effective at preventing pneumocystis in at least small trials. It's not definitively proven that this prevents toxo, though. It may be better tolerated than a double-strength tab. So my general strategy is to recommend a double-strength tab daily. I do know providers who recommend a single-strength tab if someone doesn't need prophylaxis for toxo. I've usually done a double-strength tab daily, and then if there's difficulty with general tolerability of GI symptoms and others, then potentially step down to a single-strength tab. I have not used a double-strength tab 3 times per week very often, if ever, in my primary care for HIV practice, but it is also effective at preventing pneumocystis. Now, if someone can't tolerate trimsulfa, which is relatively common for a number of reasons, I usually think of these next 2 options as being sort of equivalent in efficacy with different considerations of which one to go to next, the dapsone and the atovaquone. Dapsone is a daily oral pill for prevention of pneumocystis. Certainly some people also don't tolerate dapsone, and I have seen people develop a rash. I have seen people even with a normal G6PD level develop anemia and other side effects. So it is not a perfect drug either, and it also does not prevent toxo. So I think this is well known that dapsone does not prevent toxo. So if someone cannot tolerate trimsulfa and needs dapsone for pneumocystis prophylaxis, and they need toxo preventative therapy, then you have to add pyrimethamine or leucovorin, which adds a lot of pill complexity. There are options for weekly dosing if you're doing that, but again, I think you're adding a lot of complexity. So it's an important point to consider, especially in someone who can't tolerate sulfa and someone who needs toxoprophylaxis. Now, atovaquone prevents pneumocystis, probably prevents toxo, though there's not strong data, but it is a pretty bad tasting liquid. I think it's difficult for people to tolerate and adhere to it, and it's expensive. So certainly can be limitations in accessing it. We have gotten it for people when there are no other options, but those certainly are challenges. And then I think of inhaled pentamidine being the last option. It's monthly, it's inhaled, it sounds like it should be a really great option for people, but there are a lot of limitations. So number 1, it has been shown to be less effective at preventing pneumocystis. Number 2, it has to be given in a negative pressure isolation room with a specific type of nebulizer. Number 3, it can induce a lot of bronchospasm. So anyone with structural lung disease or a propensity for bronchospasm can come out of that inhaled pentamidine room really, really wheezy. We often give albuterol nebs beforehand to try to reduce that, but it can be difficult to tolerate. And then a big thing is we have seen instances of peripheral, especially upper lobe pneumocystis in individuals adhering to inhaled pentamidine because the efficacy really is limited by an individual's ability to inhale it and spread it throughout the lungs. So this is the order in which I consider these. We certainly have individuals who, for whatever reason, cannot receive the first 3 and really benefit from monthly inhaled pentamidine. But again, I think there are limitations. Let's talk about discontinuing pneumocystis prophylaxis for a moment, because this is something that has shifted over the years. We've talked about this on ECHO before, but I'd like to review it for a moment. So the most tried and true approach and the strongest guidelines recommended approach is to continue prophylaxis, whether it's primary or secondary prophylaxis, until the CD4 count is above 200 for at least 3 months with an undetectable viral load. So this is CD4 reconstitution to above 200 with ART adherence. Now, as we've discussed, there is data that stopping prophylaxis when the CD4 count is above 100, so between 100 and 200, with a undetectable viral load is likely safe. There are some smaller studies that are cited and that you can look at, but this is the largest study of this to date, and I think the one that really led to the adjustment of the guidelines. So this European retrospective database review that had over 23,000 people with HIV and over 100,000 person years of follow-up had just over 250 cases of pneumocystis that were documented, and they looked at the incidence and the risk of pneumocystis based on a spectrum of CD4 counts and a spectrum of viral loads. And the most important point is that if an individual had a CD4 count of 100 to 200 and a viral load before 400, there was no difference in pneumocystis incidence if they were receiving or not receiving prophylaxis. And in this spectrum of laboratory values, there were no pneumocystis cases in those who stopped primary prophylaxis. So that is the most robust data we have for stopping with a CD4 count 100 to 200 and undetectable viral load. Again, there are some smaller retrospective and at least one small prospective study that agrees with that. But so this is the wording as it was updated in the opportunistic infection guidelines. So not a strong recommendation, more a consider level recommendation. The guidelines now say one approach is to stop prophylaxis when CD4 count is 100 to 200 if the viral load has been below the limits of detection for at least 3 to 6 months. I certainly have done this, especially if individuals are struggling with tolerating prophylaxis or with pill burden. This in the guidelines has been extrapolated also to secondary prophylaxis. I'm usually a little more conservative and cautious with secondary prophylaxis when someone already has some degree of lung insult from pneumocystis and has already proven they are prone to pneumocystis. But the guidelines do say this is a reasonable approach to consider now for stopping primary or secondary prophylaxis. So I hope that is a useful review. Just a couple other notes about preventing pneumocystis. So we talked previously about how difficult it is to prevent exposure. This is a largely ubiquitous organism, and illness can occur either from reactivation of prior exposure with a declining T cell count or from new exposure and transmission from others. So the question that comes up in terms of prevention is, should hospitalized patients with pneumocystis be separated from other immunosuppressed hospitalized patients? And the answer is yes. It would be unsafe for a person with active pneumocystis to be in the same room as another person with a low immune system or with with CD4 or T cell compromise. And so this is the wording from the CDC that is recommended to avoid placement of an individual with pneumocystis infection in the same room as an immunocompromised patient. And you can see some of the reasons there and references for why there is that recommendation. So I hope that's a good reminder. Let's turn to treatment, though. I think there's a lot to consider around pneumocystis treatment. We'll start first with considering the various agents and outpatient or inpatient treatment, and then we'll talk a little bit about the dosing controversy around trimsulfa before we turn to adjunctive therapy. So first, choosing outpatient versus inpatient therapy. So I have treated pneumocystis as an outpatient, not often. I have a pretty low threshold to admit people and treat as an inpatient. But if a person has no significant hypoxia, they're able to take PO meds, they're adherent to their meds, they have close follow-up, and they really, really seem to have mild illness, It is reasonable to treat as an outpatient. The one thing, and I put here in italics, I would remember is once you start treatment, a person can clinically worsen. That is pretty common with pneumocystis. So again, I have a low threshold, and if a person has significant hypoxia, they can't take PO, they have a lot of comorbidities, or even if they're kind of on the border of outpatient versus inpatient treatment, I would lean towards treating them in the hospital because those first couple of days, they may worsen. So here's the list of recommended options per the OI guidelines for mild disease versus severe disease. For both, you'll note that trimsulfa is the option I put first here. I think it does have the best data, the most clinical experience, and again, is the most tried and true option, and usually my first choice. It's not that the others aren't effective and the others might be better tolerated, but again, this is certainly the one we have the most experience with. So for mild illness, oral trimsulfa is usually my go-to. If a person absolutely can't take sulfa, then trimethoprim dapsone is an alternative option. It might actually be as effective as trimsulfa. It is more pills though, and the asterisk here is to remind you for checking G6PD with dapsone. Clindaprimaquine is another option. Again, you need to check a G6PD because of the primaquine. And then atovaquone, it is actually per data less effective, but I have done it in people who really do not have a lot of symptoms and really have mild illness with pneumocystis. So those are the recommendations for mild illness. For severe disease in the hospital, really IV trimsulfa is our go-to. IV pentamidine is effective, but is a very difficult drug to tolerate. And if you use IV pentamidine, you will be chasing electrolyte abnormalities, blood pressure abnormalities. Over time, it can burn out the pancreas, it can burn out the kidneys. It is just a difficult drug to give, especially for an extended duration. So I have also had instances in which a person had an allergy to sulfa, such as with a type 1 hypersensitivity, an IgE-mediated rash, not Stevens-Johnson, not TEN, in which we admitted them to the hospital, started pentamidine, and also did a quick desensitization and switched them over quickly to trimsulfa. Those I would think of as the primary treatment options for a person with very severe illness with pneumocystis. Clindaprimaquine can be done. A challenge is that clinda can be given IV, but the primaquine is only available as an oral agent. So if a person is hospitalized and intubated, I generally So those are the options as outlined in the OI guidelines and as I usually consider them. If others have thoughts about your clinical strategy, I'd love to hear them as well. I'd like to just highlight, though, a bit of controversy for which we may get more data around the dosing of trimsulfa. So I've put a few notes here in the left, and I would refer you to this citation for McDonald et al. And a really nice review published last year in OFID that highlights how little data and how little evidence and how outdated the evidence we have is around pneumocystis treatment and especially around the dosing. So there has not been a randomized clinical trial of pneumocystis treatment since 1998. And if you think about that, I mean, all of this data is based on, well, pretty limited data for one, but also a patient population that was somewhat different, ART usage that was different, and critical care protocols that are different. There was no lung protective ventilation, for example, in those days. None of the trials were done with anyone with renal insufficiency. And if we think about our current patient population, which is older, has more polypharmacy, has more comorbidities, we are extrapolating a lot of data here based on very limited evidence. And actually, if you go back and look at a lot of the evidence that led to the choice of dosing and duration of pneumocystis treatment, it was based on very small trials, some done in pediatric studies, some done in people without HIV. There have been a couple of studies now, mostly retrospective and observational, suggesting that lower doses of trimsulfa are likely as effective and better tolerated. So the OI guidelines still say for trimsulfa, it should be 15 to 20 mg per kg per day divided into 3 or 4 doses based on the trimethoprim component. This is for pneumocystis treatment. But the OI guidelines do highlight that lower doses may be as effective and better tolerated, and that we need RCT data. So what's coming, what's planned, is a randomized controlled trial where people with pneumocystis, some either with HIV or without HIV, anyone with pneumocystis can be enrolled. We'll randomize them to either 10 mg per kg per day or 15. 15 is more of the standard of care. Again, 10 may be as effective and may be better tolerated. So that is coming. It's in pilot phase right now, and I hope we get data from that in the future. I hope they're able to enroll because that really could change practice. Again, I'll reference the McDonald review where they gave some opinion about for whom we might consider lower doses of trimsulfa, and I'd encourage you to take a look at that if you're interested in the topic. But with that, I'll turn to a couple other key take-home points and reminders before we wrap up. So other questions I'm often asked about pneumocystis: is empiric treatment okay? Can you start treatment before doing the diagnostics? The answer is absolutely yes, and I think that is appropriate if you have a high suspicion for pneumocystis infection. I would start empiric treatment if you suspect this infection, and then I would continue to pursue the diagnostics. The standard course is 21 days, again, mostly based on observational data. There's never been a randomized control trial comparing 28 to 21 to 14 days. It's really based on limited observations and now historical and clinical practice. So I say that to mean that most individuals will need 21 days. There may be individuals who need longer. There may be individuals who would be cured with shorter, but really that is our clinical standard and best practice and what's in the guidelines. And then here's a really important clinical reminder. Remember, when you are considering pneumocystis, to get an ABG, both for help with the diagnosis and for assessing the hypoxia, but because there are these criteria that are standards for adding corticosteroids. You can see here the PaO2 criteria and the AA gradient criteria. I think this is really important to review and to lock in and to remember to check that ABG when you're considering pneumocystis. Giving you some examples here of recommended corticosteroid courses. Should we alter treatment based on prophylaxis? Meaning if someone's been prescribed trimsulfa and they develop pneumocystis, should we choose a different option? Are they likely to be resistant to trimsulfa? The answer is no, and the reason for that is the vast majority of individuals who develop pneumocystis, even though they're prescribed trimsulfa, develop pneumocystis because they weren't taking it. And while resistance to trimsulfa has been reported, it's quite rare. So we do not need to alter treatment based on prophylaxis. And then just a huge reminder that there is solid data for benefit of starting ART within 2 weeks of starting pneumocystis treatment. Finally, I will come back to this point that pneumocystis illness often worsens in the first few days of treating, and it can be very difficult to know if a person is not responding because, well, at least for me, it has caused anxiety in specific cases of wondering whether we should be switching therapy, adding therapy, and not knowing whether it represents treatment non-response or the expected worsening. So you sometimes have to just hold in there with pneumocystis treatment. And what's in the guidelines is illness often worsens during the first 3 to 5 days, likely because of dying organisms and a robust kind of immune reaction, and often wait 4 to 8 days before switching therapy. But if you get to this point, if you get to 4 to 8 days and someone's not responding, what do you do? And there's no clear right answer. So some things to consider, and I think I've done all of these at one time or another. One is to rule out any concomitant infection that hasn't been identified. So obtain a BAL if that hasn't been already done, or repeat the BAL if it was done early in the course. Potentially switch oral meds to IV or an IV med to an alternate agent. Possibly add an agent. There is very little data around this. Now, this is an interesting point with echinocandins. Echinocandins block the synthesis of beta-D-glucan, and we use beta-D-glucan to diagnose pneumocystis, and we know that it is present in the cell wall. So why don't we treat pneumocystis with echinocandin? It's probably because that enzyme that the echinocandin blocks really is only present in the cystic form and not the trophic form. So echinocandins may have a bit of activity for pneumocystis, and there are case reports and case series of them being used as adjunctive therapy and maybe having benefit, or maybe those patients were going to get better anyways, even without it. So there are some upcoming clinical trials looking at echinocandins as an adjunctive therapy for pneumocystis in people without HIV. It's something that's been done. I'm not sure I've ever done that one actually now that I think about it, but it's out there in case series and case reports and could be considered. I would never rely on echinocandin as monotherapy for pneumocystis. Increase the steroid dose, prolong the steroid taper. I certainly have done that for people who are slow to respond. Extend treatment, extend the steroid duration, again, all considerations. So I would really think of that 21 days of therapy as being sort of the average of what someone's going to need. And then there are ways in which pneumocystis treatment may need to be individualized for the folks who are slower to respond. So that was a whirlwind review of pneumocystis prevention and treatment. I hope there were some interesting clinical points or reminders for you, and I'll stop there. Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.